Ladies and gentlemen, it's 1:15. It's Friday, and I have the pleasure of opening this keynote lecture. As you know from the opening ceremony, I'm always in for humor, and this talk will be about the vitreous humor. And please, Susanne Binder, would you be so kind to introduce Dr. Jerry Sebag?
Ladies and gentlemen, it is with great pleasure and honor to introduce Dr. Jerry Sebag to the first Robert Machemer Retina Lecture at SOE 2019. Dr. Sebag is a graduate from Columbia and Harvard, a fellow of ARVO and the American College of Surgeons and Royal College of Ophthalmologists in the United Kingdom. In the years 73 to 75, he was a fellow of the American Scandinavian Foundation at Karolinska in Sweden, and in 1978 he became a student of André Balázs, which was called the father of the Vitreous, at Columbia University in New York. In 1983 and 4, he was a Guggenheim Fellow, and he became a student of Charles Keppens, again, the father of the retina, in 1984. Dr. Sebag is an international award winner. Actually, he did win 25 international prizes and awards in England, France, Italy, and the United States. Amongst them is the American Health Foundation Prize in 1978, the Lauréat de la Société Française d'Ophtalmologie in 1984, the Treacher Collins Prize of the Ophthalmological Society of the United Kingdom, and the Honor Award of the Vitreous Society. He's an honorary member of the Beati Foundation in Rome, a fellow of ARVO, and a Career Achievement Award winner of the American Academy of Ophthalmology. Jerry is an innovative thinker and a precise and methodical researcher who is as comfortable in the lab as in the clinic or the OR. He is a prolific author of 3 books, 79 peer-reviewed articles, many book chapters, and guest editorials, reviews, and letters. He is an international visiting professor at 6 institutions currently on 3 continents, and he also speaks 4 languages. Currently, he is a senior research scientist at Doheny Eye Institute and full professor of clinical ophthalmology at UCLA. He lives in happy marriage with my dear friend Jackie. He is a father of 4, and here you see the marriage of their daughter Bree in Hawaii. He is also a grandfather of 4, and the last grandchild just was born a month ago, and his name is Hudson. Jerry is a sportsman, an avid boating enthusiast, and a fan of Latin ballroom dancing, a hobby we also share. As a friend, he is the most reliable and supportive friend you can wish for, and is helpful in all situations of life. Jerry and Jackie are the most generous hosts if you visit them in their lovely house. I personally enjoy his wisdom, sense of humor, and his support. Dr. Sebag is an accomplished lecturer, having delivered 61 invited named lecturers, but he considered the inaugural Robert Machemer lecture at the SOE in 2019 the high point of his lecturing career. Ladies and gentlemen, I give you Dr. Jerry Sebag.
Thank you very much. Mr. President, members of the Scientific Program Committee, I greatly appreciate the privilege of being the inaugural Robert Machemer Lecturer. I appreciate the keynote lecture from the SOE, but I also want to thank Cindy Toth and the Robert Machemer Foundation for enabling this to be the Robert Machemer Lecture. But in particular, I want to thank the professor and chair of the Department of Ophthalmology at the Sigmund Freud University, Susanne Binder, for making all of this possible. Danke, Susanne. In my 4 decades of being interested in the eye, the fund of knowledge of Vitreous has grown tremendously. And this can be traced by inspecting the various treatises that have been published on Vitreous, beginning with Duke Elder in 1930. At that time, he wrote about the physiology and the chemistry of Vitreous and had nothing in there that was clinical, and the monograph was 72 pages long. In 1973, George Eisner from Bern published a biomicroscopy atlas of the peripheral fundus that had many photographs of Vitreous in it. It was 192 pages. In 1989, a monograph on Vitreous attempted to unite the basic sciences with the clinical sciences and review what was known at that time, and it only took 173 pages. In 1995, Jan Wurst in Holland and Loss published their book on the cisternal anatomy of the vitreous body. It was 269 pages long. By 2002, it was no longer possible for 1 or 2 authors to write about Vitreous, and it took over 30 co-authors to put together the Rapport de la Société Française d'Ophtalmologie sur la pathologie du vitré. It was 493 pages in length. A few years ago, 90 co-authors put together the definitive text on Vitreous in Health and Disease, and it took 925 pages. So I think you can appreciate that there's been a significant expansion in our knowledge of Vitreous. Yet, we probably know less about Vitreous than any other part of the eye. My adventures in Vitreous began in 1978 when I was a medical student at the College of Physicians and Surgeons of Columbia University, and I met André Balázs, a remarkable individual who was the first person to ever say the word vitreous to me. And there were many other things that he taught me, but that resounds within my memory. In particular, Balázs taught me about vitreous biochemistry, which is rather remarkable when you consider that the vitreous body is 98% water and only 2% structural macromolecules. Hyaluronic renders viscoelasticity to the vitreous body, while collagen provides the structural framework, skeleton, so to speak, of the vitreous body. There's a very important interaction between collagen and hyaluronan that results in transparency of vitreous, but also the gel state. Unfortunately, we don't really understand the nature of this interaction, nor how it changes in aging and in disease. Balázs also enabled me to develop a way to study the anatomy of the human vitreous body by providing me with autopsy eyes, fresh autopsy eyes from the New York Eye Bank. And the technique that was developed was to peel off the sclera, exposing the choroid while leaving some sclera at the limbus, but also around the optic nerve. Like peeling a grape, the choroid can be removed from the retina, exposing a very unique view of the retina, the opposite view of what we see with our ophthalmoscopes. Here, we're looking down at the photoreceptors of the retina. Careful dissection of the retina off the vitreous body results in a specimen that's intact. And as you see in this particular specimen, can be observed in room air on a surgical towel, but still maintains its exquisite gel state because this came from a 9-month-old child. Most of these dissections have to be done underwater because of the liquefaction that exists in different ages in the vitreous body. But by placing sutures around the limbus and mounting the specimen onto a lucite frame that's then placed into a lucite chamber with an isotonic saline solution, you can create horizontal optical sections through the vitreous body with a slit lamp as shown here. These were the first photographs that I obtained in Balázs's lab of the human vitreous fibrillar structure. In all of these specimens, the anterior segment is below and the posterior pole is above. You can see that in the middle-aged human, there are fibers that course through the vitreous, inserting into the vitreous base surrounding the lens. These fibers are continuous and do not branch, and insert into the posterior vitreous cortex. There are holes in the posterior vitreous cortex, such as this one here in front of the macula and the smaller one in front of the disc. The one of the disc is a real hole. The one in front of the macula is actually just a dehiscence because of the very thin posterior vitreous cortex in that location. The turgescence of the vitreous body in these specimens broke through the outer vitreous, resulting in this appearance that you see here. This is from a young individual, and you can see Cloquet's canal opening into the retrolental space of Berger, but no fibers because it's characteristic in older individuals. We did electron microscopy in Balázs's lab to identify that there were no membranes such as the ones described by Eisner, but only collagen fibrils, often in bundles such as the ones seen here in cross-section. In 1984, I met Charles Scapins when I went to Harvard to do my residency in ophthalmology. And he was very instrumental in guiding the thinking behind a lot of the research that I subsequently undertook, and emphasized to me, and I share with you, the importance of how in medicine science has to be clinically relevant in order to make a difference, at least in 1 or 2 lifetimes. And he certainly made a great difference to the way we think about the eye and the way that we examine the eye and the way that we operate specifically on retinal detachments. So I'm very indebted to him. Under his influence, I looked at the effects of age on the structure of the human vitreous body. And you can see here in this specimen from a 33-week-old human embryo, the vitreous body is rather homogeneous. Again, the anterior segment is below. This is the back surface of the lens. This is the posterior vitreous cortex, which is composed of a very dense network of collagen fibrils. And within the vitreous body, there's not much light scattering going on, except for the remnant of Cloquet's canal. This is where the hyaloid artery resided during the first trimester and part of the second trimester of embryogenesis. The reason for this homogeneous appearance is because the hyaluronan molecules separate the collagen fibrils by at least a critical half-wavelength distance so that light scattering is minimized. The vitreous body remains transparent, and a maximum number of photons can reach the retina so that vision can begin. Apologies to the corneal surgeons. During embryogenesis, the first trimester is characterized by a structure that is filled with blood vessels. The hyaloid artery feeds the vasa hyaloidea propria, which anastomoses with the tunica vasculosa lentis and the pupillary membrane. And here you can see the appearance of the embryonic hyaloid vessels. By the end of the second trimester, the vitreous body is clear. This is an incredible phenomenon that nature can undertake to eradicate a structure filled with blood vessels and make it completely transparent. And I think that if we are able to learn the secrets of how nature is able to obliterate these blood vessels, it may give us tremendous potential in developing new drugs to treat metastatic carcinoma, but all of the proliferative neovascular disorders that afflict our patients. And we began this with a proteomics study, but I'm hoping that this will be picked up by others and things will progress so that we can have new rationales, new approaches to the treatment of neovascular disorders using the vitreous as a model, because nature has figured out a way to do this rather reproducibly in most, if not all, people. Studying the age-related changes results in the concept of a fibrous liquefaction of the vitreous body. In the top panel, you can see from a 4-year-old and a 6-year-old individual, here again we see the back surface of the lens, there is scattering from the dense collagen matrix of the peripheral vitreous, the vitreous cortex, but within the vitreous body there really isn't much to speak of. By middle age, fibers have formed with an antero-posterior orientation coursing from the vitreous base all the way posteriorly. By old age, these fibers become thickened and tortuous and associated with liquefied vitreous. There's an overall collapse of the vitreous body and a transition or transfer of the liquid vitreous that has formed into the space between the vitreous and the retina. This is an important consideration, especially these days, because the anatomy of the vitreous body is not taken into consideration when intravitreal injections are administered. And you can well imagine that there will be a difference in the distribution of drugs of an injection into this part of the vitreous as compared into this part of the vitreous, where there's a lacuna of liquid vitreous. And so I think this is part of the explanation why we have experienced variability in patient responses to intravitreal injections. The same hands injecting the same eye with the same needle and the same drug will not always have the same response. And I think that one of the ways to improve drug therapy of the posterior segment is to take into consideration the structure of the vitreous body and somehow control where exactly we're injecting and study how that gets distributed through the eye. Our current concepts are rather simplistic and I think need to be advanced. The other phenomenon that's very important is the vitreoretinal interface. We know that there's a strong adhesion in youth and that somehow this weakens with aging. But because we don't really know how the vitreous is attached to the retina, we don't really understand how that weakens and how that results in aging changes. Willie Halfter in Pittsburgh has demonstrated the age-related thickening of the inner limiting membrane, and you can see here with increasing age, there's increasing thickness. But that's really just a superficial perspective, and we need to go deeper into the problem in order to understand what does that thickening mean, what components are there that are resulting in the weakened adhesion between the vitreous and the retina. Because the most common event in the life of the human vitreous is posterior vitreous detachment. And there are two critical components for a posterior vitreous detachment. You have to have liquefaction of the gel, but also weakening of vitreoretinal adhesion to allow the collapse of the vitreous body. And both of these are required in tandem for an innocuous PVD to occur. When you have liquefaction without vitreoretinal dehiscence, an anomalous PVD can result. And the manifestations will vary depending upon where the gel is most liquefied and where the vitreoretinal adhesion is strongest. And we discussed at a symposium organized by Professor Binder earlier this morning the clinical consequences of anomalous PVD at the level of the macula, so I won't go into it here. Even when there is concurrent gel liquefaction and vitreoretinal dehiscence to allow the posterior vitreous to separate away from the retina, patients can still be afflicted by floaters. The reason that patients are afflicted by floaters is not entirely clear. I used to think it was simply because of this dense collagen matrix in the posterior vitreous cortex. Of course, this is a bit exaggerated because of the dehydration that scanning electron microscopy requires. But I think there's something more to the issue. And thanks to Carl Glittenberg and Susanne Binder, we have this incredibly beautiful demonstration of the posterior vitreous when it's separated from the retina. And one of my concepts is that it's an irregularity in the detached posterior vitreous that may have a very damaging effect to light transmission to the retina not just the thickness of the posterior vitreous cortex. And I like to model this mathematically and explore this further, so if there's anyone in the audience interested in pursuing this, I'd love to speak to you later. In this image of ultrasonography, you can see that the posterior vitreous is separated, but there's also a lot of echo density in the central vitreous. And both of those probably induce the scattering that induces floaters. And we've experienced that the most common cause of vitreous floaters is a PVD. The second most common cause is myopia, and this is an increasingly important problem. It's quite different because in myopic patients, typically they're younger, so they don't have a posterior vitreous detachment. Yet there are opacities, the consequence of aggregation of collagen fibrils into structures that interfere with photon transmission to the retina, create the scattering that results in the phenomenon of floaters. This is a growing problem because studies have estimated that by the year 2050, there'll be almost 5 billion people in the world with myopia. And if myopic vitreopathy plays an important role in their disturbed vision, we need to pay attention to that because it's going to be a growing problem. So the real question in considering vitreous floaters is whether this is a nuisance or whether it's a disease. If you ask the patients, it's clearly a disease. Studies have shown that the negative impact of vitreous floaters is considered equivalent to AMD and greater than glaucoma and diabetic retinopathy. Patients bothered by vitreous floaters are willing to accept a 7% risk of blindness and are willing to exchange 1 out of 10 years of remaining life just to be rid of their floaters. Yet doctors don't consider floaters a disease. Typical doctor would say it's a nuisance, there's no tear or hole in the retina, you're fine, deal with it. And I must tell you that we have not met the needs of our patients suffering from vitreous floaters. That callous attitude that we've brought to the discussion has not fallen upon favorable ears. Patients are quite unhappy when they leave with the information that we give them. It's not a problem, you'll get used to it, go away. And I think that this is a call to all of us to look at this problem from the patient's perspective and not simply pass them off. But why exactly do we not consider this a disease, or have we not considered this a disease? I believe it's because of the absence of objective clinical indices of structural and functional abnormalities with which to define vitreous floaters as a disease. We like to measure things. It makes it much easier for us to be able to understand it and to be able to stage it as mild, moderate, and severe. And we haven't had that for vitreous, and we haven't been able to evaluate patients with vitreous floaters in this manner. And this hampers the acceptance of vitreous floaters as clinically significant. So we've dedicated several years of R&D into defining objective and quantitative metrics of vitreous structure and visual function in patients who have vitreous floaters. But we started by giving it a name, and I call clinically significant vitreous floaters vision-degrading myodesopsia. Now, I'll be the first to say that that doesn't really roll off your tongue. It's not really an easy thing to be tossing about in a conversation about vitreous floaters. But gosh, it sounds like a disease. And I think psychologically, that's the first step in beginning the process of getting doctors to accept vitreous floaters as a disease. We began by measuring contrast sensitivity function. And this was at the suggestion of the ever-brilliant Alfredo Sadun, who said you should measure contrast sensitivity function. It might be reduced. My first reaction was negative. I didn't understand how could these little things inside the vitreous make a difference in contrast sensitivity function. But he was correct. We used the Freiberg acuity contrast test developed by Michael Bach at the University of Freiberg, where the Weber index is defined as you see listed here. The thing to remember about the FRACT is that the lower the Weber index, the better the contrast sensitivity function. And in our hands, the FRACT test has a reproducibility of 92%. We began with a small prospective study of individuals who had their contrast sensitivity function measured, which was normal, then developed a PVD, which was bothersome to them, and we found that there was a 54% worsening in their contrast sensitivity function. In each case, vitrectomy reversed it back to normal. A larger study, which was retrospective of 139 patients who had significantly bothersome vitreous floaters, found that the average contrast sensitivity function was 4.6% as compared to age-matched controls, which were normal at 2.4%. And again, the higher the Weber index, the worse the contrast sensitivity function. This represented a 91% worsening in people who were bothered by their floaters. So we're quite content that this represented a quantitative index of visual function that might be useful. We then sought a structural correlate, and we used quantitative ultrasound to evaluate the vitreous structure in collaboration with Ron Silverman and Jonathan Mamou in New York, where we send them 10-second recordings of the ultrasound, and they have developed an algorithm to quantify the degree of echo density. The first finding was that patients who have PVD, shown here in blue, have worse contrast sensitivity function than patients with no PVD. And of course, these patients are younger. So there may be confounding elements to this. But then when we looked within the group that had PVD, there was an increase in their Weber index, which represented a decrease in their contrast sensitivity function with age. So perhaps after the vitreous detaches, it continues to change in a manner that interferes with the transmission of light to the retina and degrades contrast sensitivity function. We correlated the vitreous echo density with quantitative ultrasound and contrast sensitivity function, and found that the greater the echo density of the vitreous, the worse the contrast sensitivity function. So having these two indices with which to evaluate patients and grade them in terms of mild, moderate, and severe opened the door to embarking upon A, a consideration that this is truly a disease, and B, what can we do about it? One of the treatment options is YAG laser treatment. Unfortunately, to date, there's no proof that YAG laser vitreolysis works. Delaney and colleagues published in 2002 a comparative study where in the cases that underwent YAG laser treatment, 62% had no effect, while 38% claimed only a moderate improvement. In comparison, or actually in contrast, to the patients who had vitrectomy where 93% improvement occurred. But there were no really objective measures in that study. A Cochrane database system review concluded in 2017 that YAG laser vitreolysis has no basis at the present time. They didn't say it doesn't work, they just said that there's no scientific evidence that YAG laser vitreolysis works. A recent publication out of Boston claimed that YAG laser vitreolysis of the Weiss ring was effective. But if you drill down and look at the numbers, you find that there was only about a 54% improvement, and it only occurred in about 53% of patients. So it works half the time and only by half. And I published a letter to the editor concerning that study, pointing out that that's perhaps because YAG laser does not ablate. It's a photodisruptor. And it takes large particles and renders them smaller, but necessarily more of them. And the net effect may not be improvement, I think, accounting for these disappointing results. That brings us to Robert Machemer, the gentleman after whom this lecture is named, quite appropriately, and in perpetuity. The Robert Machemer Lecture will hopefully honor this great individual. As you know, he was originally from Germany and moved to the Bascom Palmer Eye Institute between '66 and '77. He became the chairman at the Duke Eye Center in 1978 until his retirement in 1991. And Robert was a remarkable man because he had similar traits and combination of similar traits to other great individuals. He had old world traditional values and discipline, but new world boldness. I saw those same combinations in André Balázs, Charles Schepens, and Susanne Binder. And I believe that that underlies the important work that he did. When some of his disciples found out about this lecture, the first thing that they said was, well, it's a shame Robert couldn't be here to hear the lecture. And so thanks to Kirk Packo in Chicago, I was able to organize a slight savor, flavor of Robert Machemer for us to share today. Can you make it louder, please?
If you want to do something new, then you have to dare do it and not shy away from it.
And true to his words, Robert Machemer had the courage to try something new, and that was the development of vitrectomy. He was fortunate enough to be able to work with a brilliant engineer named Jean-Marie Parel, originally Swiss, recruited from Australia by Ed Norton to Bascom Palmer. And together with a fellow Helmut Büttner, they were able to design an instrument to conduct and undertake vitrectomy. And here you can see a photograph of the first instrument. It simply represented a hypodermic needle with a drill bit within it. And the concept that they developed was that this instrument should do cutting, as well as infusion, as well as suction. And here you can see the first instruments that were developed. If you want to get better insight into the story of the development of vitrectomy by Machemer and Jean-Marie Parel, please refer to the chapter in the Vitreous book where he has all of his early engineering drawings, such as these magnificent ones that you see here, that he made by hand and colored by hand and reflect the state of the art in those days, making their achievement all the more remarkable. So the product or instrument that they developed was a combined instrument where all three elements were contained in one instrument.
So we modified the vitreous cutter into a vitreous infusion suction cutter.
In 1970, Robert Machemer performed his first pars plana vitrectomy. It was a success.
In spite of that initial success with an instrument that performed all three functions, you all are aware that evolution of this technology resulted in the three functions being separated: an infusion line, fiber optic illuminator, and a suction cutter in a third instrument. There was quite a lot of invasiveness in the early days, quite a lot of inflammation. The instruments were large, required suturing. And the evolution of this technology to sutureless micro-instrumentation is what made me more comfortable to offer vitrectomy to patients suffering from vision-degrading myodesopsia. My preliminary experience with this was a retrospective study of 76 cases, followed for an average of 17 months. There were no cases of endophthalmitis, retinal breaks or detachments, vitreous hemorrhage or glaucoma. One patient developed macular pucker, and 23.5% of patients developed cataract postoperatively at about 15 months after vitrectomy. The 16 cases that had abnormal contrast sensitivity function preoperatively were normal at 1 and 3 months. The prospective study that I alluded to earlier was a small study of 8 patients who had normal contrast sensitivity function when we first met them, developed a PVD, and had degradation of their contrast sensitivity function, but a limited vitrectomy resulted in normalization 1 month postoperatively, and this was sustained for 1 year. A much larger study, which was recently published in Ophthalmology Retina, consisted of 195 eyes and 146 patients. And you can see the demographics listed for you here. 122 of those were phakic individuals. The cause of vitreous floaters in this group of individuals was 50% in most cases, and the mean age of these individuals was 63. 16% had myopic vitreopathy, and their mean age was 41, but 28% had both myopic vitreopathy and posterior vitreous detachment. And in my experience, these are the most unhappy people because they have both the aggregation of collagen within the vitreous body as well as collapse of the posterior vitreous, introducing the effects of PVD, compounding what they have from myopic vitreopathy. Interestingly, only 6% of patients had asteroid hyalosis. The outcome measures that we employed in evaluating these patients were the NEI VFQ-39, quantitative ultrasonography, visual acuity, and the measurement of contrast sensitivity function as I described. The results from an efficacy standpoint were quite remarkable. Satisfaction increased by 30% in terms of general vision, and role difficulties improved by 32% as subscales of the VFQ-39. Quantitative ultrasound demonstrated that a limited vitrectomy was able to decrease the number of structures within the vitreous body that were greater than 0.07 millimeters in diameter by 94%. Visual acuity improved from 2030 to 2025, and this was statistically significant, but visual acuity is really not a good measure of what's happening to these individuals. Contrast sensitivity function, however, is, because in every one of these cases, it improved. And here you can see a bar graph of the patients with floaters, numbering 139, in whom we had contrast sensitivity function measurements preoperatively as compared to age-matched controls. And there was 91.3% degradation in the floater patients. Within 1 week of surgery, contrast sensitivity function was normal in every single case. And as you can see, it has remained normal for months and years. A rather remarkable result that was comforting to me because, as you can well understand, it was rather controversial to set out on this course. And to see these kinds of results that result from objective quantitative measures was very reassuring that I was on the right path. Complications occurred very infrequently. The average follow-up in these 195 patients was 32 months. And as you can see, there were 22 people followed for more than 5 years, 50 people for more than 4 years, 69 for more than 3 years. This is a long-term evaluation. There were no cases of endophthalmitis and no problems with intraocular pressure. Vitreous hemorrhage occurred postoperatively in 2 cases, but it cleared spontaneously and did not require intervention. There was 1 patient who developed cystoid macular edema. Retinal breaks occurred in 3, while retinal detachment occurred in 3 others. The retinal detachments happened in 1 case 2 weeks post-op, in another 10 months post-op, and in the third 14 months post-op. And you could argue that the 14-month post-op retinal detachment was not really related to the vitrectomy, but I share it with you for full transparency. In the individuals who did not have a PVD at surgery, I do not induce a PVD surgically. And the question always arises, well, what happens to those individuals? Do they get into problems later? And there were only 4 cases that developed a PVD that was symptomatic, that caused them floaters, that did degrade their contrast sensitivity function, and underwent a second procedure, which was uneventful, corrected the problem, and restored their contrast sensitivity function back to normal. Another possible consequence of not inducing a PVD surgically is the development of macular pucker, and that only occurred in 2 cases. They underwent surgery that was uneventful and most effective. Retinal artery occlusions occurred in 2 elderly gentlemen in their 70s with systemic hypertension, and we don't believe that it was in any way related to the surgery, but again, I share it with you for full transparency, as was the case of 3 patients with retinal vein occlusions. In this particular series of patients, cataract surgery was required in 16% of individuals. The mean age of the people who required cataract surgery was 64. No one under the age of 53 required cataract surgery. This is a study that was done in collaboration with colleagues at the University of Amsterdam who perform extensive vitrectomy in contrast to the limited vitrectomy that we perform. And by limited, what I mean is that not only do I not induce a surgical PVD in those individuals who don't have a PVD, but I also leave 3 or 4 millimeters of vitreous behind the lens because it contains antioxidants as well as the matrix for new antioxidants that arise from the ciliary body to mitigate against the effects of free radicals of oxygen that induce cataract formation. And what we found was that following extensive vitrectomy at 24 months, 87% of patients required cataract surgery, whereas following limited vitrectomy, only 35% required cataract surgery. Furthermore, the average time of onset of the cataract surgery was much shorter following extensive vitrectomy than following limited vitrectomy. In the future, this line of research and development will hopefully progress along 2 paths. In terms of diagnostic, structural evaluations of the vitreous body may be laser-based as opposed to sound-based, giving us a magnitude of improved sensitivity. Perhaps swept source OCT can be developed to visualize the entire vitreous body, or some other imaging modality that will enable us to better evaluate the vitreous body from a quantitative standpoint. In terms of visual function, we are developing a questionnaire similar to the VFQ-39, but specifically oriented to patients who have vitreous floaters. I also think it's important for us to incorporate eye and head movements because vision is a dynamic process, yet our evaluation of vision seems to be very static. We don't take into consideration the types of eye and head movements that people experience on a daily basis. We don't have ways to measure that. And I think that in talking to patients with vitreous floaters, you gain an appreciation for how head movement and eye movement really interferes with their visual function. So it would be very nice to have better tests with which to evaluate that aspect of vision. Another thing that people experience on a daily basis is fluctuations in ambient lighting. You go from light to dark and the reverse, yet we don't really have standardized clinical ways to evaluate the effect of different lighting conditions on vision. And it's been my impression that that is a significant component of the affliction that besets patients with vision-degrading myodesopsia. In terms of future therapeutics, it's possible that there'll be an optical correction. If we can understand exactly what is happening on a biophysical level, perhaps we can introduce filters or other ways to optically correct for the aberration created by the vitreous opacities. Vitrectomy may be improved with 27-gauge instrumentation, although I doubt it, or some other form of non-cutting removal of the vitreous and the opacities in the vitreous may improve our approach with vitrectomy. I don't know whether YAG lasers are going to be modified in any way to improve efficacy, but I do suspect that femtosecond laser may be more of an ablative treatment than YAG lasers have been, and there may be an advantage to using nanoparticles that particularly well absorb the wavelength of laser light that's being used to ablate the collagen within the vitreous body. And then lastly, there may be a role for pharmacologic vitreolysis in obliterating the opacities in the vitreous body that create vision-degrading myodesopsia. So in conclusion, vitreous floaters have a significant impact on the quality of life. We believe it's by reducing contrast sensitivity function. The quantitative indices that we have employed, contrast sensitivity function and quantitative ultrasound, as well as the VFQ and hopefully the VFFQ specifically designed for floater patients, enable us to define vision-degrading myodesopsia as a disease. And these clinical metrics are useful for case selection, but also as outcome measures. At the present time, it appears that limited vitrectomy, as I've defined it, is effective because it normalizes contrast sensitivity function and it improves patient well-being. There are few short-term and even fewer long-term complications. Therefore, I think it's safe to conclude that this is a safe procedure. At least it's safe enough if we're to fulfill the goal of modern medicine, which should be to help people die young, as late in life as possible. Under normal circumstances, I would end my lecture with this highly philosophic and very relevant quotation. But given that this is the inaugural Robert Machemer lecture, I would like to leave you with the most famous quote from Dr. Robert Machemer, that is that progress comes from doing the unconventional. So once again, I'd like to thank the program committee, Monsieur le Président, Professor Binder, for the honor and privilege of being the inaugural Robert Machemer lecturer, and I thank you for your rapt attention.